My name is Dr. Malik. I work at Advanced Surgeons in Birmingham, and I do primarily endocrine surgery, so thyroid, parathyroid, adrenal gland surgery, along with general surgery as well.
Most people don't even know they have parathyroid glands. What do they do?
Yeah, and I encounter that frequently in the clinic when patients come to me and say, well, I was referred to you for surgery, and I'm not exactly sure what these things are. And so that's always a good starting place when I'm talking to my patients, just having them understand exactly what the parathyroids are. And in summary, they're basically calcium managers is kind of how I frame it. So their goal is to manage the calcium levels in your bloodstream. And they do that by releasing a hormone called parathyroid hormone that acts on a lot of different places in the body. So it acts on the bones to help release calcium into the bloodstream from the bones, acts on the kidneys in various different ways, and it also acts on the intestines to help absorb more calcium from the foods that we eat. So several different ways that it works, but that's kind of the underlying function, is to keep your calcium at a real happy, kind of perfect spot.
How do people usually know that or what are some signs and symptoms someone might have of a parathyroid problem?
Yeah, so it's usually pretty subtle. And so it's rare that it gets picked up just from purely symptoms alone. The most common way it gets picked up is an elevated calcium level in a blood test. So your standard screening blood test you get at your primary care doctor. And then with some more history and a little bit more digging, you can usually figure out what's going on. But a lot of patients will have osteoporosis or osteopenia. Several patients will have kidney stones. Those are some of the more objective things that we can measure, that you're truly having some downstream effects from having a parathyroid problem. And then there's some more subjective things like forgetfulness. Some people say brain fog, fatigue. Some patients will even say that they just felt like, they were getting older at a certain pace, and then all of a sudden they got really old really fast. And so there's almost like this aging feeling or sensation that people can have. A lot of them do get better. Yes. So some of those subjective things are a little bit harder to measure and a little bit more variable from patient to patient. So those feelings typically get better. Those sensations and joint pains and aches get better. Certainly we see there's several good studies showing that bone loss is reversed and the risk of fractures is decreased significantly in patients who have this corrected, typically surgically. And risk of kidney stones, if you're someone who has kidney stones, goes down as well. So certainly a lot of improvement in those things if we can correct it.
Okay. How do you usually decide how do you determine when surgery is needed for the different types of parathyroid disorders?
Sure. So the main parathyroid disorder that we see most commonly is called primary hyperparathyroidism, which means there's a primary issue with the parathyroid glands themselves and not a secondary cause or something else that's telling the parathyroids to overproduce hormone. And so in primary hyperparathyroidism, if your calcium levels are above the normal limit and your parathyroid levels are also high, that tells us that something's out of balance. And there's some other factors we can check into to make sure that we're not getting confused by other things that can throw off those numbers. But once we rule all of those things out, we typically can narrow it down and say, this is a parathyroid problem. Surgery is typically the next step. And there are some ways we can localize maybe which one it is. Most of us have 4 parathyroids, and oftentimes it's a one-glanded issue where we're just taking out one gland to correct the problem. And in other folks, it's a 4-glanded issue or a multiple gland issue where we have to take out more than one. So a couple different flavors or variety of parathyroid disease, but from a primary hyperparathyroidism standpoint, calcium, PTH are your first sort of markers that something might need to be done. There are 2 approaches, minimally invasive and a 4-gland exploration or a full neck exploration. Typically, if we know that it's a one-glanded issue, we think we have a suspicion it's a one-glanded issue, which we would know by imaging for the most part. So if we have an ultrasound and a CT scan that both sort of point in the direction of a single gland, then we can limit the operation to going after just that one gland. And typically that's a little bit less invasive of an operation. Oftentimes, how that works is in the OR, we take out the gland while you're still asleep. We check your PTH levels, the parathyroid hormone levels. They should drop while you're still sleeping. And if we see an adequate drop, that tells us that we've fixed the problem. We don't need to look at the other glands. And there's a 98% certainty that we've fixed things just by looking at the one. Sometimes that level doesn't drop, even if the imaging told us it's that one. And that clues us in that we need to look at the other 3 glands. And so that's sort of the difference between the two. The cure rate's about the same between both. And if you can find all 4, you don't necessarily have to rely on the PTH in the OR. You can go based on the look of how they all look compared to each other, and compared to your past experience of seeing other parathyroid glands. And we also rely on the pathologist. So we use labs in the OR, we use our eyes, and we use the pathologist to look under the microscope all while you're asleep so that we can hopefully have a guaranteed good outcome before you even wake up.
So your thyroid's here.
Mm-hmm.
What does a parathyroid gland look like?
For most people, a normal parathyroid is about the size of a grain of rice. So about 6 to 7 millimeters. They're yellow. They kind of match everything inside of you. So they can be tricky to find. They sit behind the thyroid. So normally we're having to roll the thyroid over to look behind it. And they normally weigh about 50 to 60 milligrams. And so that's kind of a normal one. If you have one big one, sometimes they can be as big as 3,000 or 4,000 milligrams at kind of the upper extreme. But certainly an abnormal one will look bigger, redder, a little bit angrier. So it gets a little easier to figure out.
Interesting. Okay. What are some risk factors with this type of surgery, and how do you go about minimizing those?
Yeah. The biggest 3 things that I always talk to patients about that I worry about are giving them the opposite problem. So taking their calcium from too high and going too low. And that would only happen in the case where all 4 parathyroid glands are injured or no longer functional. So you only need half of a normal one to function to manage your calcium levels. So we have a lot of extra built in. Ways that we minimize that is obviously being gentle around the parathyroids. They're very sensitive. If we don't need to be exploring the other ones, we don't. And even if one looks normal but maybe has lost blood supply, one thing we can do is actually remove it, cut it into small pieces, and reimplant it in the muscle right there, and it'll come back to life. So they're interesting little fellas. So we have some insurance against that one, typically. Other things I worry about, bleeding, common with any operation. I usually tell patients I don't worry about bleeding in the OR. I can see that and I can stop it. What I worry about is bleeding afterwards that could cause difficulty breathing, where you have to rush back to the OR and wash things out. So very rare that happens. And for the most part, we minimize that risk by a couple of maneuvers we do in the OR to make the patient breathe deeply and expand any veins. So if we see any bleeding, we can stop it while we're looking at it. We watch them as long as we need to in the recovery room to make sure there's no bleeding issues. And most patients, if they are going to have the misfortune of bleeding, which again is way less than 1% risk, it's going to happen within the first 2 hours after surgery. And so we watch them for at least 2 hours. We check the incision. There's no expansion or bruising or difficulty breathing. 95% of patients are safe to go home same day.
Oh, okay. So outpatient?
For most folks, it's outpatient. Yeah.
How do you help patients understand the link between parathyroid health, energy, bone strength, all those things?
So I take a lot of time to explain because, as you mentioned, a lot of folks don't know what parathyroids are. So that's kind of where I start. And I have a picture usually in the clinic that I draw on that the patient goes home with, but basically shows where the parathyroids are. We go over normal physiology, so kind of the normal relationship of what calcium and PTH should be doing and how they should be balancing each other out. And then I draw sort of a picture of what the patient has, which is typically an imbalance of calcium and PTH. And if there's an imbalance, what that can do, similar things we talked about with regards to driving calcium out of the bones into the kidneys. And once you sort of paint a picture of normal and a picture of what's going on with the patient, I feel like they have a pretty good grasp on.
That's interesting because I didn't think about the concept of pushing calcium out of the bones into the kidneys.
Yeah.
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 Crazy.
So that's something we talk about. Sometimes we can do urine tests to see how much calcium's in the urine. And basically, if you see a high level, I tell the patients, you're basically peeing your bones right out into the toilet. You're losing them, so it's not ideal. And that, is the unfortunate side effect of it. And hip fractures, any types of falls, fractures, those kind of things can be pretty detrimental, especially older patients. We think about risk of death is about 50% in 1 year if you have a hip fracture. And so it's a big life-changing, hopefully, event we can prevent by taking care of this. After surgery, there's really not a lot the patient needs to do. If they were on calcium supplements, or a grand majority of these patients are typically females in their 50s to 60s, postmenopausal, some even older. So a lot of them are already on like a women's health supplement or diet vitamin. So I always tell them it's okay to restart that, but you don't necessarily need to take extra calcium long term. The main thing to do is just keep following up with your primary care provider to get your calciums checked yearly. And any basic lab test should have a calcium in it. I tell patients there's about a 1% chance that this could reoccur in a different gland. And so the way you'd pick up on that is just by watching the calcium levels over time. And if you start seeing uptick, you come back and see me, and we kind of repeat the workup and make sure we're not missing a new gland or something else that's been acting up.
Yeah. And what makes your surgical approach uniquely patient-focused?
The thing that I hear most back from patients that they appreciate is the time that we take together to go over the normal and abnormal differences. Again, because this is not something that's more typical of surgery, where most surgical problems, you have pain. You have stones in your gallbladder that are hurting when you eat. And so it's kind of obvious we should take out the thing that's causing pain. Or you have a hernia that we can see and that we can push on. So it's not something that has a lot of, patients aren't typically well educated on. So I think that's sort of my focus of that visit. And that I think patients appreciate is educating them, making sure they really grasp what's going on. And I think the other thing is, not being pushy. So I think this is certainly something a lot of patients have had for years. I always tell them it's something we should take care of, but it's not emergent. They should take time, read about it, come back and see me. So I'll never force, not that you can force anyone, but I never push anyone to have surgery. I just kind of lay out what's normal, what's not, what I think is the best approach, and let them decide what they think is best. I think with complications, one that patients often think about or that ask about is also voice nerve injury. So that might be worth addressing as well. So the voice nerves track out of the chest. They're called the recurrent laryngeal nerves. They track beside the parathyroids, kind of behind the thyroid, plug into the voice box and give you the voice that you have. And so we obviously worry about those because you use your voice every day for everything you do for the most part. And so one thing we do a lot of different things to make sure we're seeing the nerve with our eyes during the surgery and keeping it swept away and protected. We also use a nerve monitor in the OR. So there's a voice nerve monitor that's connected to the breathing tube that's in during surgery. And so when we see the nerve with our eyes, we can test it with the nerve monitor and confirm we're not getting tricked. Because patients don't have labels like an anatomy book when we are looking on the inside. And so we confirm with two different modalities. And then we sweep that nerve away and make sure that there's no injury or hopefully no permanent voice changes with that. And it's, again, way less than 1% risk of injury for that.
Is this the only type of surgery you do?
No, so I do thyroid, parathyroid.
Okay.
So anything related to the thyroid or in the neck, for that matter, with regard to the endocrine glands, and then general surgery as well. So gallbladders, hernias, adrenal glands, also in the belly, but an endocrine organ as well. So one patient that really kind of stood out to me was a lady with parathyroid surgery. We had already operated on her. She told me at the post-op visit that before surgery, she actually was having suicidal thoughts. She didn't tell me that she was feeling suicidal before, but she did say she had some depression, anxiety, which is common with parathyroid disease. But after surgery, she felt like those symptoms completely went away. That's when she was telling me that those kind of sad thoughts and feelings just improved rapidly. Kind of the next day, she said it was kind of profound how quickly it turned around.